Dr. Poornachandra is a senior consultant in the Department of Vitreoretinal Surgery at Narayan Nethralaya. He has vast experience in managing these cases and also has extreme interest and experience in retinal dystrophies and management. Thank you, Dr. Poorna.
So good morning everyone. Thank you Dr. Sharon for the opportunity. So I'll just try to cover some of the basic aspects of the managing, taking care of the posterior segment when you people encounter with a case of trauma. So in case of an open globe injury, there are different zones which can be involved in a trauma. So as long it is confined to the zone 1 and zone 2 as it is seen in the diagram, it can be handled by an anterior segment surgeon. Once it extends to zone 3, it's always better to involve a retina specialist. So similarly in the closed globe injury also there is a classification, there is different zones of injury. So but most of the time it's not an emergency condition. You can give the primary treatment to handle the anterior trauma in terms of traumatic uveitis and all that. But it does require referral to a vitreoretinal surgeon irrespective of the zone of trauma. Even if it's in the anterior segment, there could be some transmitted effect which can cause posterior segment problem. I'll explain the same. So the mechanism, what happens in closed globe injury is, there could be coup and counter coup injuries. Coup means the initial force caused directly by the trauma. Counter coup is because of the transmitted shock wave. In closed globe injury, what happens is there will be compression, decompression, overshooting and oscillations. So whenever there is a compression, so once it comes back to the normal position, it is not always a benign event. The reason being the vitreous is relatively inelastic and cannot stretch when the eyeball is rapidly decompressed. So that's where most of the problem happens, and this vitreous will start pulling on the retina and can cause bleeding, the other problems. Fine. So this was a 21-year-old male who presented to us with a history of blunt trauma. So he had a kind of opacification which is confined to the posterior pole. So this is one of the most commonest posterior segment change what we see after a blunt trauma. This is commotio retinae. When it is limited to the posterior pole, we call it as Berlin's edema also. It is characterized by transient gray white discoloration or opacification, may be confined to the macula, or sometimes you can notice a cherry red spot mimicking a central retinal artery occlusion also. So the symptoms are usually determined by the location. So the course and management, usually there could not be any visual complaints if it is not involving the posterior pole. As the retinal opacification resolves, the vision may return to normal, and it tends to recover in majority of the cases, except in this severe macular involvement with other associated problems. Otherwise it's a benign thing. Most of the time without any treatment also it can resolve. So the second case is an interesting, the 28-year-old male with history of firearm injury. So he was in a function where they traditionally they fire the bullets, and some bullet passed next to him. He doesn't know how it passed and all that. So this is a typical case of chorioretinitis clopiteria. It is a distinct closed lobe injury, typically caused by a transmitted shock wave of a high velocity missile penetrating the orbit, grazing but not perforating the sclera. Okay, it's all because of the transmitted shock wave. So one clinical feature immediately following the injury, there could be acute vision loss, extensive retinal and choroidal hemorrhage as well as tears in these layers. The sclera always remains intact. The pre-retinal and vitreous hemorrhages are often present. The lesion heals with or without development of a fibrous scars. So how do we manage? It looks very bad, ugly. Once we see that there is a lot of pigment release, the retinochoroidal ruptures and all that. The primary goal is with the clopiteria is to make a prompt and accurate diagnosis. That is more important. You should not get confused with a occult rupture. So despite the lesion striking appearance, only observation, no surgical intervention is the appropriate initial management. You should not do anything. Once you are sure the globe is intact, no intervention. So pars plana vitrectomy may be indicated in case if there is a vitreous hemorrhage which is not clearing. The prognosis obviously depends on where this lesion is passing. If it is excluding the macula, there are cases who have recurred up to 20/20 vision also. Okay, because most of the times the choroid and retina, they retracts at a single unit, so it doesn't allow retina to detach. They heal by scar formation. So this was again one more 32-year-old with history of blunt injury. blurred vision, it's like a spotter. You all can see that there is a macular hole in the center where you can see here. The traumatic macular hole is relatively a common complication after a contusion related injury, may occur within hours of incidence and believed to account for fewer than 10% of all macular holes. The incidence could be around 1.4%, and it always happens in closed globe injury. Open globe injury, usually we don't see macular holes unless it is complicated by some other things like PVR formation and all that. And traumatic macular hole usually typically ranges in size between 0.2 to 0.5 disc diameter, and this is how they look. Most important thing is these are most of the time young patients and the PVD is absent. So the pathophysiology of this hole is different from what the idiopathic macular hole what we see in old age. For the same reason, the management is also different in traumatic macular hole. The hole occasionally may close spontaneously with complete recovery of visual acuity, and 50% spontaneous closure is seen in children. The younger the age, the better the closure rate. Okay, so the moment you see macular hole, it doesn't mean that you go and do a vitreoretinal surgery and try to close, especially in traumatic macular holes. So in adults, the spontaneous closure rate is little less, but it is possible. So this was a 17-year-old boy. He came to us with a history of stick injury 1 week prior to the presentation with a vision of 6/60. Other eye was normal. This was the traumatic macular hole. So this is 1 week post-trauma, and this is 1 month post-trauma, and this is 2 years later. It has closed on its own spontaneously with a good recovery of vision. So whereas the second case was a 36-year-old, followed by an RTA, he had a macular hole, traumatic macular in the better eye. Other eye was already lost to some other trauma. So the vision was 6/60. When we examined, in addition to the macular hole, if you can see there are a lot of pigmentary and scar formation surrounding that. And these kind of macular hole, usually they don't close. So this is the corresponding OCT, and this requires a prompt referral to a VR surgeon, where we did a vitrectomy, ILM peeling and gas injection. So post-operatively, the hole did close, but vision acuity did not improve to a great extent. It remained at 6/60, but over years, they may tend to improve up to 6/24 or around 6/18. So coming to the vitreous changes in blunt trauma, which is the commonest cause for referral to a vitreoretinal department, it could be disinsertion or hemorrhage. Disinsertion can happen because of the vitreous base avulsion or optic nerve or along the retinal blood vessels. The commonest changes are avulsion of the base of the vitreous with or without dialysis, PVD with retinal tear, or a vitreous hemorrhage. So whenever you see a pigments in the vitreous, it's an indication to carefully search for a retinal dialysis or a tear. It's a thumb rule. The moment you see pigments in the vitreous in a trauma, you have to rule out associated retinal break. So vitreous hemorrhage can occur from various causes. In case of closed globe injury, it could be because of retinal tear, posterior vitreous detachment, scleropeteria, optic nerve avulsion, cyclodialysis, iris tear. It could be, the cause could be anything. The moment you see the vitreous hemorrhage, it's very difficult to determine from where the blood has come. It could be because of this. And prognosis also depends on what's the root cause for vitreous hemorrhage. It has happened due to optic nerve avulsion. Obviously, you can't do much about it. So when you do a B scan in vitreous hemorrhage, the traumatic vitreous hemorrhage will always have a uniform dot echo throat. There won't be compartmentalization like subhyaloid hemorrhage and all that, which happens in proliferative diabetic retinopathy. So the pattern will be little different. So how do you manage this? So associated with closed globe injury, vitreous blood usually managed with close observation is spontaneous clearing of the blood. That's what we do. Usually wait for minimum 1 month for it to clear. But in between, warn the patient about the possible complications. We do vitrectomy only in case of there is an associated retinal detachment. It fails retinal dialysis. So this is basically a suppression occurring at the anterior edge of the ora, more common than generally perceived. So most frequent traumatic retinal break as compared to any another retinal break almost always occurs at the time of injury. Unlike this, vitreous remains attached to the posterior edge of the dialysis. That's why usually the chances of RD and PVR formation are less. Prognosis is relatively better compared to other form of breaks. And that vitreous attachment is probably the reason for the slow progression in case of this dialysis. So detachments, even if it occurs, are seldom bullous, usually smooth, thin and transparent. The star folds or other proliferative vitreoretinopathy changes are very rare. The features of chronicity are very common because they could remain asymptomatic, and it usually carries a good prognosis. Management, as I told, in the absence of any retinal dialysis, this thing you can just do a laser cryopexy, cryoretinopexy or a laser, barrage laser. Barrage laser is most preferred as compared to any other form of treatment because the chances of complications are less. So occasionally dialysis will seal spontaneously also because of the vigorous chorioretinal response or an insult. So early recognition of the dialysis is the key in avoiding and more extensive intervention. Associated RD, we usually do a scleral buccal in most of the cases. In rare cases where it extends to the macula, if there is a total detachment, you do vitrectomy. Otherwise, most of the time, it will settle with the scleral buccal itself. So coming to the peripheral retinal breaks, the common source of post-traumatic detachment, the location and the configuration of the fluff U tear tends to mimic those associated with the spontaneous PVD, something like this. So the symptoms could be a floaters, photopsia, blurred vision, primary or secondary vitreous hemorrhage. So depending on what is causing the symptom spectrum could be different. The retinal detachment in case of horseshoe tear is much greater as compared to the dialysis which I just described. In most cases, the contusion related tears are located inferotemporally. The reason being the bony orbit affords less protection in this area and eye is rolled upwards due to Bell's phenomena associated with impending approach of a noxious stimulus. For that reason, usually this break tends to be more in the inferotemporal quadrants. Management, again in most cases traumatic tears should be treated with laser retinopexy. It's not like dialysis where you have an opportunity to wait and watch. The moment you see the tears, it requires an intervention either in the form of barrage laser retinopexy and cryopexy is less preferred. So holes that have undergone spontaneous closure due to chorioretinal adhesion can be observed sometimes. So one more case example, this was an adult with history of injury with stone. You can see some concentric semicircular whitish opacification in the macula. So basically this is a choroidal rupture. So this can be two types, direct occurring at the site of impact or indirect away from the site of impact. The indirect ones are always located near the macula due to tethering effect of the optic nerve. Usually these tends to be concentric to the optic disc. So the prognosis of the injured eye can vary. So maybe initially poor due to overlying hemorrhage, improves as the hemorrhage resolves. If it's a subfoveal rupture, obviously vision tends to remain poor. If it's extrafoveal, patient can maintain 6/6 vision also. So treatment, if there is an associated submacular hemorrhage, you can observe, or sometimes we can do something called pneumatic displacement, where we inject 0.3 cc of 100% C3F8 without dilution with paracentesis, and patient is advised to maintain post position for 2 weeks with minimum of 6 to 8 hours per day, with or without tissue plasminogen activator. So this is the post treatment. It is completely resolved with the flat macula. So coming to the last part, just 2-3 more slides. So intraocular foreign body. So intraocular foreign bodies account for 18% to 41% of the open globe injuries. 50 to 88% of post-traumatic IOPs resides in the posterior segment. So young men constitutes about 92 to 100% of the patient, and 66% have average age between 21 to 40 years. The common place, obviously workplace is common, followed by home. The commonest cause in 60 to 80% is hammering. If the patient comes with a trauma and he gives an history of chiseling or hammering something, always with a breach in the eye wall, always suspect an intraocular foreign body. Even if your B scan is not able to pick up, to be safe medico-legally, if you have time, get a CT scan done. Okay, so most of the time patient may tell, no, andar nahi gaya, it fell off and all that, but still you need to roll out the intraocular foreign body. So the appearance, immediate, there could be scleral wound, bleeding, cataract, retinal breaks or endophthalmitis or inflammation. The later on, it may develop into a retinal break leading to detachment and proliferative vitreoretinopathy, glaucoma, metallosis like sidrosis in case of iron foreign body, hypotonia, all those things can happen. When you do a CT scan, you need to be aware the kind of suspected foreign body. If it's a glass foreign body, if it's a metallic up to 0.5 mm, it can be easily detected. Whereas in case of glass, the detection rate is 96% if the size is more than 1.5 millimeter. If it is less than that, it's only 48%. That is, still there is 50% chance that you might miss a glass foreign body on CT scan also. So B scan signs of foreign body, you're all aware, like echo dense signal corresponding to the foreign body, the way you can see here. So the persist at low gain, high reflectivity on A scan, shadowing posteriorly. So the size less than 0.5 millimeter may not be produced shadowing. None. So sometimes in case of open globe injury, then associated air bubble can get confused with the IOFB. You can differentiate by, air is usually regular and spherical. You will have similar echo appearance and moves with the head tilt, and if you follow it up, it will get observed. Whether it's not the same case with the foreign body. So when do you remove the foreign body? You do an early intervention that is less than 24 hours if there is a signs of endophthalmitis, retinal detachment, toxic intraocular foreign body in terms of copper and all, or one-eyed patient. Delayed repair in case of life-threatening other associated injury, if there is an inert IOFB, if there is no endophthalmitis and corneal clarity is poor, and if there is a lack of settings, you can operate later. So this is the last slide, and this is the video showing the giant metallic foreign body. So we do vitrectomy. First thing is we have to mobilize. I have not included many surgical videos because it may not be appropriate to this forum. So first you need to mobilize the foreign body by clearing all the membranes, attachments and hemorrhage around the foreign body. Then engage the foreign body. So these type of large foreign bodies are difficult to remove through the entry wound, that is scleral wound. You may have to do a lensectomy, and better to remove it through the corneal route. So you can use magnet so that you can align it to the cornea or where you want to extract. So this, as I told, we are extracting it through the cornea itself, and this patient, the mode of entry was also through the cornea. There was a cataract, it was easy. So otherwise you may have to sacrifice the lens and extract it. So to conclude, I would like to say it's very tricky when it comes to posterior segment trauma. The prognosis can range from, so completely a normal recovery to a PL negative. So, but medical legal aspects are very important, and prompt reference to a particular specialty, either neurophthal or a retina specialist, very important. Thank you so much.
Thank you very much, Dr. Poorna. That was really a comprehensive coverage of posterior segment trauma. I'm sure everyone in the audience also has so much experience, and you'll agree that each case is so different. Any questions from the audience or a case which you would like to discuss or ask anything about?
Whether the globe is collapsed, is there any very big foreign body? That's all you are trying to do. Just fill the entire thing with the gel, just place the probe, and just if you get an idea, that is more than enough. And if you are suspecting a foreign body, in case of open globe, B scan is not the way to confirm. Better, go for a CT scan. And again, it's a tricky thing. If you can get the CT scan very fast, then do it. Otherwise, we have seen patient will be going around getting the CT scan report and all that. By that time, the eye would have gone for panophthalmitis. So first thing is to close it as early as possible. That is also important.
Yeah, please. Please ask. Do we have a mic? You can take the mic, doctor.
In an open globe injury, if the injury is very severe and there is a big scleral perforation, but the posterior extent of which is not found, it's beyond equator, what should we do?
So you will, you want to take?
It does happen. Most of the time, blunt to injury ruptures, posterior may not be traceable. In these scenarios, I strongly recommend to disinsert the rectus. So once you disinsert the rectus, most of the time you will be able to, reach the posterior extent. So that's the only way. Otherwise, what happens without disinserting the rectus? If you try meddling it, you will be, applying more pressure on the intraocular content. It may expulse out. So disinsertion, if you have a squint colleague, it's well and good. Otherwise, you yourself can do it. It's not very, here we are not going to recess, resect, measure, squint aspect. Just cut it at the insertion, keep the temporary suture, and resuture it to the sclera. So that will, because the prognosis here, we are not worried about patient develop squint or not. We have to close it. So I strongly recommend to disinsert the rectus depending on the quadrant in which your stare is extending.
Yeah, definitely what Dr. Poornachandra said. So unless you have, if you have not reached the posterior extent of the tear, then you know for sure that there's going to be a leak and that eye will definitely go into athysis very, very early. So yeah, disinserting is the way to go, because it helps you also to